So coming to the physiotherapy management, the main goal of these kind of fracture, rehabilitation of these kind of fracture is restoring knee range of motion, maintain mobility of hip and ankle joint, improve and restore the strength, normalize the gait pattern of the patient, and the most important one is to return to the functional participation. So when we are talking right now of rehab of the proximal tibia fractures, we'll divide it into week wise rather than um, phase wise. That becomes quite easier for us to have a record of what are we aiming for. As we said previously, the primary aim is to improve the range of motion, right? So day 0 to day 1 week, we'll see that we want the range of motion to be till 40 to 60 degree. So we'll make sure that it is achieved, and to achieve that we'll need to do some active assisted knee range of motion exercises. We have to make sure that the extremity is elevated firstly, so that fluid retention is minimized. Ankle toe movements and all general mobility exercises of hip and ankle should be started to maintain the range of motion of hip and ankle. We need to make sure that we are avoiding the valgus and varus stress on the joint. So while giving the knee range of motion, we can ask the patient to do heel slides, then active assisted. Uh, we can passively move the joint so till that range 40 to 60 degree. So that is our goal one. CPM can be used, but it is quite dicey. Like it totally depends on the stability of the fracture. Some there are some advances which we are going to see in the later part of our discussion. That there are some recent advances which states that CPM is effective in improving range, but it is found to be having a short-term effect rather than a long-term effect. So that totally depends on the fracture stability. Over here, there are some pictures that I have put here. You can see the limb is elevated over here. We are giving hip flexion, abduction exercises, but we need to make sure that while performing this hip flexion and abduction exercises, that the limb needs to be supported by a brace. Usually, long knee brace is prescribed in these cases. So, long knee brace can be prescribed for these patients, and we need to do the exercises adhering to the criteria over there. Knee range of motion exercises till 60-degree since we are aiming. Heel slides can be given. Active assisted over here in sitting position, high sitting, can be given with the assistance of the non-affected limb of the patient itself. And the patient will be told to do shown previously to how to do the exercise, and the patient does it on his own. Over here, ankle range of motion exercises can be started. With respect to muscle strength, no muscle strengthening will be given for knee muscles, as it's just day 1 or week 1. So no strengthening exercise will be given, but yes, we need to give isometric strengthening for the quadriceps. We can start that. Isotonic exercise of plantar flexors and dorsiflexors can be ankle plantar flexors and dorsiflexors can be given without resistance. Glutes statics, as I said, isometric exercise can be started in this phase. Weight bearing status, weight bearing, we need to avoid weight bearing for 3 months, which is the according to the orthopedic criteria. We need to make sure that we are not uh, asking the patient to bear weight for 3 months. But again, there are some articles which states that early weight bearing has found to be very effective, which we are going to see in the later part of the PPT. Then functional activities, we ask the patient to use a crutch, and now this crutch and walker, it totally depends on your patient, how old your patient is. If there is a younger patient which you are treating, or younger population which has been had an accident with for proximal tibia fractures, so we'll prescribe crutches for them. And if the patient is elderly, walker is usually prescribed. So gait for those is with the crutches. For the younger adults, we usually give 2-point non-weight bearing gait, and elderly toe touch weight bearing can be given. But while giving toe touch weight bearing, also we need to make sure that you make the patient understand that it just you have to touch your toe over there, not bear full weight on your extremity. These are some exercises: statics and non-weight bearing with crutch and walker. At 2 weeks, usually we want the range of motion to be 90-degree. So active and active assisted knee flexion exercises can be continued till that range. Then muscle strengthening quadricep isometric exercises are to be continued. There is this article which states that early quadriceps strengthening after surgery of proximal tibia fracture, tibial plate 2 fracture is very important. See, the fracture, it is said that the fracture affects the terminal stance phase of the gait cycle and reduces the single leg support of the affected limb. So when quadricep muscle contracts in the effort to bring the femur above the tibia, these patients during gait cycle reduce the flexion of the affected knee and make their single stance shorter. So from 4 to 6 weeks, we continue with active assisted range of motion, and gentle passive range of motion can be given over here. See, till 6 weeks here, the range of motion is written 90, but we progress it to 100-degree or 110-degree. So this gentle passive range of motion, prone knee bending and all you can give if the range of motion is not achieved till that time. And we continue with ankle and hip range of motion. Strengthening can be started in now for with resistance in for the ankle and plantar flexors and dorsiflexors. But isometric strengthening for quadriceps and all are continued. Over here, if you can see, these are the diagrams. Again, the functional activities we use crutches for transfer. The gait pattern is similar, which we had discussed. That is 2-point non-weight bearing gait using crutches for younger patients and toe-touch weight bearing using walker for elderly patients. 8 to 12 weeks, aggressive range of motion exercises should be instructed, including active, assistive, and passive range of motion exercises. Full range of motion should be achieved by 12 to 16 weeks. So usually the rehab protocol is for 12 to 16 weeks, and we even start with balance training and all in these phases right now, because the range usually is achieved if we follow a good physio rehab protocol. We design a proper rehab protocol. By 12 weeks, the range of motion is full, and we start with weight bearing now. So gentle resistive trainings of quadriceps, hamstring, ankle can be given. Then partial weight bearing using crutches is given. Weight bearing activities are started. Partial to full weight bearing at the end of 12 weeks. So we start weight bearing from before 12 weeks, and by the 12 weeks, we'll make sure 12 to 16 weeks, we'll make sure that we are weaning off from the assistive device and the patient is doing his day-to-day activities properly, bearing weight properly on the limb. So now in these phase, we usually recommend balance training, including balance training, weight bearing, and all everything. You can see here, there's a diagram of resistive band training for the knee musculature. Over here, the patient is been tied with a weight cuff for strengthening of extension. Over here, you can see the patient is being tied a TheraBand over here for extension, terminal knee extension. Over here, half or ham curls, the weight cuff is being tied over here. And the patient is doing SLR with weight cuff over here. Here again, we can use a TheraBand in place of weight cuff for the same. Resistive band can play an important role. We usually give it in our clinical setup. Over here, you can see the strengthening of the hip muscles and dorsiflexor, plantar flexor. And over here, proprioceptive drills are given. Proprioceptive drills are done. So coming to the articles which state that we had discussed regarding the CPM. Here it is given that the CPM, CPM has been proven to CPM has been proven to improve the range of motion in post-operative tibial head fractures, but the duration for that is 3 times a day for 30 minutes. But a systematic review indicated that CPM had small short-term effects on active and passive knee flexion range of motion, and no evidence supporting the presence of long-term effects of CPM on active or passive knee extension range of motion, pain, swelling, and quadriceps strength. So that is an important point that we need to understand, that CPM has a smaller effect, and we should not you know design a protocol keeping the CPM in our mind. There's one more article of physiotherapy after tibial plateau fracture fixation, a systematic review of the literature. Here in this, you can see the range of motion exercises, either active range of motion, active assisted range of motion, or passive range of motion for knee can be started early, immediately after surgery, at second POD, or once wound healed after internal fixation of the fracture. See, the the range of motion totally depends on what kind of implant that is being used and what type of fracture it is then, right? So if there is an external fixator or any circular frame is used, we usually delay the range of motion exercises for 6 to 8 weeks so that the fracture is healed properly. Whereas if there is open reduction internal fixation with plating and all, we usually nowadays start with early range of motion exercises, uh, as it is also proven that immobilization does not provide any additional benefit, and most of the focus of the rehab program should be on the quadriceps strengthening and proprioception exercises in these cases. So that's why we can start with range of motion exercises early on second POD. Immobilization. So the other one more part of these kind of fracture is how much time it should be immobilized, right? So as I said that long knee brace is usually preferred in these cases after surgery. But can we totally be dependent on that kind of brace? No, we cannot. So after some days, after there is an internal stability or fixed immobilization period is done, we usually switch the patient to hinge knee brace. So the patient can do the knee range of motion movement, but it also provides a stability to the joint, and it does not hamper the healing process of the joint, but also there is some kind of movement of the joint. There is a study in which it is shown that immobilization of 6 weeks had poor outcome. So fixed immobilization should not be more than 2 weeks. If you remember, we had started weight bearing in these cases in the rehab program a bit later on, right? So weight bearing over here, partial weight bearing can be started 6 weeks, followed by weight bearing between 6 to 12 weeks. So again, this is for again fractures with a higher complications. There are some articles which also said that we can start weight bearing earlier too, but not we don't need to keep the patient in non-weight bearing status for 3 months continuously. Okay. Ongoing rehab should be focused on quadriceps training and proprioceptive exercises that are to avoid gait impairments on and functional limitations in long term. See, when you limit a patient, when you limit a person from doing any activities, it takes a toll on his psychological health and his quality of life. So us as a physio, our main goal for the patient is to make him functionally active, take him to his pre-fracture uh time. So he should be able to do the activities, everything, and we need to accelerate it. So if we keep on limiting, delaying the weight bearing status and all, or delay the strengthening, the proprioceptive exercises and all, So it kind of hampers his day-to-day activities and his quality of life in return. This is a systematic review in which early weight bearing of tibial plateau fractures treated with ORIF, a systematic review of literature. So it is said that early weight bearing can be considered as safe and effective in selected cases after internal fixation for proximal tibial plateau fractures. So this is a systematic review which states that you can start with early weight bearing as soon as you can. But again, the keyword over here is selected cases. Again, the type of fracture plays an important role in the rehab program. Sometimes we are too rigid in some cases. Now we shouldn't get overboarded with like let's start with weight bearing early. Yes, this is the article which states that early weight bearing is recommended. Why don't we start it? But you need to understand that the type of fracture plays an important role. If you are giving it to the fractures of the medial compartment, which already bears a lot of stress while weight bearing in type 6 also, and you're giving weight bearing, obviously there's chance of collapse are more. So we don't want that. So we need to make sure you are selecting cases which which can help in improving the quality of the life of the patient and not inhibiting it, and not we don't want to have a fracture collapse or so. Over here there is a fracture on the lateral compartment, if you can see, and this is a plating, then locking plating. This article over here states that immediate weight bearing after osteosynthesis or proximal tibia fractures may be allowed. Again, there are many articles which state that immediate weight bearing and mobilization could potentially reduce the risk of post-operative complications such as DVT and have a rapid, secure recovery to pre-fracture ambulation level of the patient. But it again totally depends on the type of fracture, as traditionally, it is not allowed due to articular fracture collapse, fear of articular fracture collapse. But these anatomical shaping locking plates with subarticular screws could improve stability and allow greater loading forces over here. So this is according to the contour of the tibia. So what happens is, since it is at the similar level of the contour of the tibia, it helps in taking the weight properly of the movement, and um, helps in taking greater loading forces. There is this one more article with of anti-gravity treadmill rehab. In this article, they have given anti-gravity treadmill rehab for patient with proximal tibia fracture, and they have analyzed the data after 1 year. They have done it for to see the improvement in gait and muscle atrophy in these patients. So the they had concluded that patients who had undergone post-operative anti-gravity treadmill rehab had lesser symptoms and higher quality of life and significantly better gait and muscle atrophy, reduced muscle atrophy. So this is the anti-gravity treadmill. They have designed a protocol for training. Over here, you can see they have divided it into 6 weeks. Like they have given it for 6 weeks, and they have given week-wise protocol that what was the duration of the visit and the speed during that, and how much weight, body weight was being taken. If you can see, they have not increased the incline in article. The weight bearing, the partial body weight is 20 kg, which is same for all the uh, body part. Then the speed is 5 minutes for 1.5 kilometer per hour. They have they, if you can see in week 1 or 2, the speed has been fluctuating. Like therefore, one time they have kept it 1.5 to again 1.5 to 2. Similarly, they have increased the speed in week 3 and 4, but they are just switching back and forth between 3 to 3 to over here the same way, but they are increasing the speed, but at not constantly. Like they are making sure they are maintaining the pace. So yeah, these are the references for proximal tibia fractures, which I have done right now. But again, the same thing. When we are dealing with these kind of fracture, we need to understand that the fracture type plays an important role, and our main goal as a physio is to improve the quality of life of the patient. So if we can, improvise it by accelerating the rehab protocol, that's very good. But we need to also make sure that we are not hampering the patient by uh, you know causing an articular collapse or so. So we need to just make sure that we are not getting overconfident and uh, taking the type of fracture into consideration. The fractures that are on the medial side of the uh, tibia, towards 4, 5, 6 are high intensity fractures. Usually do not, unnecessary poke it, you can say, unnecessary, give weight bearing to that kind of fractures, because we do not want to have articular collapse. So in type 4, 5, 6, we usually say that delay the weight bearing. It's okay. Just make sure you're working on the range of the patient and just wait for the fracture to heal properly before taking any kind of you know decision on the weight bearing status. Whereas type 1 kind of fracture, you type 1, type 2 kind of fracture, you can surely start with early weight bearing. But again, the type of weight bearing, you need to make sure you cannot ask the patient to directly fully take weight of their limb in these in any kind of fracture. So we'll start with toe touch weight bearing as tolerated by the patient. As tolerated is the keyword. We cannot, we usually say let's start with 25% and then 50% and then take it forward. But it is not feasible in our clinical setup, and we cannot ask the patient to measure it accurately. So what we usually do is we as the patient, we start from toe touch weight bearing to as tolerated by the patient. As much as the patient is comfortable with, as much as the patient can tolerate, and we do not go overboard with the weight bearing of the patient, and just focus on range first and strength. And this is weight bearing is accompanied by it. Okay, that's it from my side for today. These are the references I have said. The main reference for this is Hoppenfield book, Treatment of and Rehabilitation of Fracture. This is the book which I had followed for this designing this PPT. But there are some decent advances. Obviously, do not think that if I have said the way range of motion should be till 2 weeks, 90 degree. But it totally depends again on the type of fracture and how old your patient is. Okay, sometimes even uh, wait till suture removal, we aim for 90 degrees. So it's approximately 2 weeks. So you don't need to wait that long for that. And there are some recent advances which we have seen for weight bearing. So early weight bearing, there are too many articles for early weight bearing, and you should honestly read about it more, because I think early weight bearing do have an effect, honestly, but we just need to make sure that we are tackling we are just holding a proper type of fracture for that. All right. Thank you so much for listening to me. Thank you so much for listening to me. I will meet you with another session for Physio TV. If you have any issues or if you have any questions, please drop down on the questions in the comment section. We'll surely reach out to you. Thank you so much for your time. Thank you.